All right, everyone. Again, David Johnson here from the Fort Drum Regional Health Planning Organization. We're here again for our monthly Telehealth Learning Collaborative. Good to be with you all. Just some logistics for you as you get into the webinar today. At the bottom of your dashboard for GoToWebinar, there's a spot for you to enter questions and comments under the chat button, so feel free to use that. And then also, please don't forget to enter your audio PIN. I think most of you have done that, but that's the only way that we can unmute your line. So if you haven't received that PIN, just let me know, and I'll send you that PIN. But we have a number of things to talk about today, as always. So looking forward to the conversation. Today we want to see if there are any updates from DOH, OMH, and OASIS. So we'll want to talk about that a little bit. I have some information there. And then we're going to have Katie Cook from AHI share a few thoughts from her experience at the ATA annual conference. And then we'll open that time up for you as well to share any updates or thoughts, key takeaways that you might have from the conference. And then we have a very special presentation from Vivify Health and my good friend Neil McComas. So we'll go to that toward the end of our webinar today. And then we'll mention just a couple of key events that are coming your way. Okay, so with that, I'm just going to check the screen here for a little bit and see if we have anybody from DOH on the line. If you are from DOH, could you just raise your hand for me? If you look on that GoToWebinar tab, there's a spot to raise your hand under the attendees section. So Russell Bell just hit that for us. Thank you, Russell. And I don't see anybody from OMH on the line. And I know that Amy Smith, our friend Amy Smith from OMH, could not join us. But she asked me to share with you just a quick update for those of you who are engaged in behavioral health, in the behavioral health area. There was a recent webinar that CTAC did. CTAC is the Community Technical Assistance Center for New York State, and they serve all behavioral health agencies in New York. They did a presentation called Telepsychiatry and Overview, and that's on the CTAC website. Our friend Amy presented at that webinar and gave a really nice overview of the regulatory environment from OMH. So as soon as that becomes public, hopefully I'll be able to send that out to you. Let me see, I think I got a note here that maybe Sarah Osborne from OASIS logged on. I see that she's logged on. Sarah, I just sent you the audio pin, so if you could enter the audio pin, we could unmute your line and maybe get a quick update from you. While she's doing that, I wanted to also mention that we heard from Amy Smith at OMH that DOH and OASIS and OMH continue to work on the regulatory environment, language being used, and apparently they're meeting on a bi-weekly basis right now to kind of collaborate and add some consistency to the language that they're using. And so Sarah has now joined, and Sarah, I've unmuted your line. Welcome to the Learning Collaborative. We can hear you fine. So would you like to kind of share some thoughts, what you're hearing, what you're any updates for us, really?
Well, we just finalized a new draft of a regulation, and we're still going through some internal reviews of it. But one of the problems or issues that we're trying to resolve is to be able to have patients located at a in-community site that's staffed by clinicians from certified programs, and then have that person who could be an enrolled patient or a potential patient be connected with a practitioner at one of our certified sites to have an admission assessment or medication monitoring. So we're working on fitting that within the statutory framework that we have right now. So that's where we're working, and we're sharing those ideas with the Department of Health and mental health and OPWDD, and getting some feedback from them.
Great. Well, again, we're just really excited that you guys are talking together, and that collaboration seems to be working well, and glad you're making steps toward that. I guess Rayanne has joined too. I'm going to keep Sarah's line open, but Rayanne, if you want to jump in there, any thoughts or feedback?
Oh, sure.
Hey, Rayanne.
Sorry for being a little late. Those meetings, the interagency meetings between OMH, OASIS, OPWD happened just before this meeting, so that's why a lot of us are
just joining us.
Yeah, they're supposed to end at 2, but they often go over because there's so much to discuss. So we did just get off of that, and it is, you know, I feel like work is progressing. We're making some headway with trying to reconcile a lot of the different regulations and guidance that is out. The only other update I had was that the Project ECHO RFA application period was, it ended Friday, May 5th. So we're in receipt of some applications that will be reviewed over the coming weeks, and hope to have decisions made in June for that procurement.
So June's coming very fast. So not too long to review those proposals then, huh?
Yeah, the funding is the federal SIM funding, and we're dealing with, I think, about 18 to 20 months of funding left in that. So the review team is trying to make decisions as quickly as possible so that you know, we can maximize the amount of time that the applicants actually can implement the work. Great.
Well, again, Rayanne, Sarah, so appreciative of you guys being on the call and giving these updates from time to time. I know sometimes we have a number of different questions that come in for you guys, so glad you're here, and appreciate your input as we continue to see telemedicine expand. So thanks again. If you guys have any questions for Sarah or Rayanne, please feel free to raise your hand or send me a chat box question. Happy to do that. Okay, so with that, I'm going to kind of turn things over to Katie now. And Katie, if you want the screen, I can certainly make you a presenter at this point, but
no, I'm just going to talk.
Going to chat away? Okay.
Yes.
Yeah, just why don't you give us a sense about the ATA conference. This was Katie's very first conference, the big national conference. So take it away.
Thanks, David. So I got an overarching theme from the ATA that it was really all about the value proposition of telehealth, proving the value and safety of telehealth to those against it, and finding the champions to do this work, and really sending home that message that telehealth does not replace the face time with patients. It only adjusts the amount of time spent with patients. And that organizations that are still very much in favor of fee-for-service and not value-based payments will likely fail, to be honest, at adopting telehealth. An interesting comment that I heard on the last day was that too many organizations are stuck in pilot purgatory. And I can certainly sense that myself. I've been in this position for about 6 months, and it's really all been about soft launches. There needs to be more muscle behind these pilots from larger stakeholders, though, to move them into more permanent service offerings. So it's understandable, but really finding those partners that are really going to help you to move that needle forward. Some of the breakout sessions were very interesting. I attended a few on remote patient monitoring. It's interesting what other parts of the country are using remote patient monitoring for, largely used for diabetes patients of all ages and less for the aging population with chronic conditions, which is typically what we see up here in the North Country. The key is to really work with the quality department of your organization when you're looking at remote patient monitoring so that you can get some data behind the work that you're doing and show evidence-based outcomes. Typically with hospitals and remote patient monitoring, some of the breakouts really said that hospitals are on board with remote patient monitoring, but typically only for about 30 days because they need to fill beds and they need to get paid. It's understandable. With remote patient monitoring, engaging the patient is probably the most important. Knowledge, teaching them about caring for themselves so that you can break that cycle of high utilization of the system. There was one particularly interesting study done in rural parts of Mississippi with diabetics, and they ended up saving $189 million per year and making it a reimbursable service in Mississippi. This was a large hospital system that conducted this study. Some pretty interesting stuff. There was a lot of information on telebehavioral health, telemental health. It's called many different things. Just briefly mentioning that the overarching goal is to really eventually offer therapy in patients' homes, especially veterans' homes, as many veterans tend to be nervous to leave their homes, and that providers working with the veteran population should have military cultural competence training. Overall, I really just got the feel that we need to just continue moving the needle forward, ensuring that reimbursement is solid in every state. And from a federal level, I know that sometimes we get nervous when talking with providers that they are not against telehealth, but they just don't want to go down that avenue because reimbursement hasn't been ideal for them. So I think if we just keep doing the good work that we're all doing and having the conversations and trying to move the needle forward, that, you know, we can, in Northern New York, we can keep up with these large hospital systems in major cities. Of course, hopefully someday, you know, maybe one of our programs can get highlighted at the ATA. So it was a good conference, a lot of people, a lot of vendors. Most of the vendors fell into 3 business models that I saw. Lots of software, doctors on carts, gadgets. It was hard to differentiate between all of them. At this point, I think we're no stranger to the fact that technology is no longer the challenge. So while the vendors were interesting to look at, some of them, you know, I wasn't there to shop. I was there to listen and bring some information back. So it was a good time. It was a good conference. A little overwhelming for the first-year attendees, but I did it.
Excellent. Thanks, Katie.
You're welcome.
Your opportunity now, if you would like to provide some thoughts, feedback around the ATA annual conference, go ahead and raise your hand. Again, you can do that under the attendees box in the GoToWebinar dashboard. So any thoughts, comments? Let's see. All right. I don't see any thoughts or comments coming my way, which is fine. That's great. I just wanted to make sure that you had the opportunity to share if you wanted to. I had to miss it this year, so I'm relying completely on Katie's feedback, and really appreciate that. So let me turn now. Oh, go ahead, Katie.
I have a lot more takeaways, like on a nitty-gritty level. So if anybody wanted to hear more, they can always reach out to me.
Yep. That's great. And I'll provide our contact information at the end here so everybody has that again. Good. So let me turn things over then to Neil McComas. Let me first introduce Neil to you. Neil is from Vivify Health, and they worked with us about 2 years ago now. Many of you may have been aware that we had a remote patient monitoring project that was live and active, but that company we were working with exited the healthcare space. And so we put together a fairly in-depth request for proposal and sent that out to about 9 different companies looking for their input. Then we had each of those respond to that RFP and did a pretty thorough examination of all those responses. Had a full day of demonstrations with a select group that scored really well, and far and above all the other organizations, Vivify Health really impressed us to a large degree, and we just recently then got active with the remote patient monitoring project with Vivify, and now have 16 patients that are being monitored. And so we're really excited about that project and thought it would be great to have Neil McComas share some thoughts about what it is that he's doing, what they're doing at Vivify. So Neil, I'm going to turn it over to you. I've just made you the presenter at this point. So if you can launch up there. Yeah, I think we can see it, Neil.
You got it, Dave?
We got. Yep,
can you hear me?
Can hear you too. We can hear you too. Yep.
All right. Well, I'm 2 for 2 so far. I'll keep going with that. Well, David, thanks for the kind introduction. Just want to make sure that, can you see when I move my cursor on the screen?
We can.
Okay,
so
great.
That makes a good pointer for you, and we can hear you fine.
All right, excellent. Well, thank you. Thank you for the introduction. Thank you for the opportunity to jump on this call with the Telehealth Partnership Group. Very compelling what you guys are doing. I shared this story with David just as a brief anecdote. I had hired into Vivify about 2 years ago, and one of the first, in fact, the first activity that I found myself immersed in was responding to the RFP and the RFQ for FDRHPO. And so I was baptism by fire. I familiarized myself with some very interesting tenets of what's going on with the RFP then, and since then it's been a very productive and intriguing partnership, and look forward to continuing on with that, David. So thank you for all your support.
Thank you, Neil.
You bet. So the ideas today, I'm not too big on death by PowerPoint, but I had been asked to come out and have an opportunity to present to you a little bit about Vivify Health, what we do. And so these are the main tenets of what I'm hoping to cover today, just very briefly. Trying to make this a brief snapshot of who we are, a brief history of who we are, what our current market position is, how we can impact both the clinicians and the patients, and essentially how ease of use of our product translates to workflow optimization and positive outcomes. And then for those of you that are, as Katie had mentioned, Katie made some great observations about ATA. Katie, I'd say you're 100% right on the target there. Another factor that's key out there is the administrative oversight. How do you have a discussion with IT in terms of investing in a remote patient monitoring or a telehealth initiative, and what does it mean for your IT organization? So we'll speak a little bit to that. And then another point that you touched on is a takeaway from ATA. I don't know if David did this as part of his genius by putting your statements first and then having me present second. But the idea that you discovered at ATA, what used to be a positive clinical outcome was a feel-good moment, and it was the right thing to do for the patients for all the right reasons. But now with the maturation of reimbursement and the shift from fee-for-service to value-based care, those positive financial or clinical outcomes are really translating and are commensurate with financial and business outcomes that are also positive. So the two are now symbiotic, and we'll speak a little bit to what we've been able to yield from utilization of the Vivify platform. And David, just to go back and revisit, I want to make sure I'm sensitive to the time factor. I've got, what, 15 minutes or so to kind of spin through this? Is that all right?
That's perfect, Neil. Thanks.
You bet. Okay. I need to do one thing with my screen here. Let me, I want to see this. No. I'm going to move this box. How do I minimize this box in the upper right corner on my screen, David? I'm sorry, I should have asked this before.
I'm
going to minimize that because I can't.
Yeah, there's at the top of the thing. Do you see a little minimize box there,
yep.
or view in full screen mode?
Oh, there. That's much better. Okay, good.
Yeah,
it's getting
we actually couldn't see it actually. So.
Yep. All right, I've got it. All right. Sorry about that hiccup, folks. Well, back in '09, we were founded by a management team that had largely been collectively together. Our clinical, executive, clinical, financial, technical leadership team has been together, working together for about 15 or 20 years, previously as members of a different company. Really, what really fueled our liftoff was a couple of investments through Heritage Group and Ascension Ventures. And really, that's translated to our ability to initially give us the license to hunt with over 600 hospitals. A partial list will be on the forthcoming pages here, but we're rapidly expanding internationally, and we are pretty fairly consistently viewed as an innovative leader in the digital health world. Part of what we do is we describe ourselves as a three-legged stool, where we are very much involved in the remote patient monitoring, and we're very much involved in population health management. So that would go back to Katie's observations on the quality initiatives that many facilities are getting involved in. And then as a subset of remote patient monitoring, we are also a telehealth vendor, and we have some virtual visit capabilities and capacities that we take advantage of. So we're keeping a very close eye cast toward the reimbursement of telemedicine and telehealth. I know those two terms should not be used interchangeably, so I don't mean to do that, but that's something that we definitely have a keen eye cast toward, and we're watching closely. Trying to advance this screen here. It's not working. I'm locked up. Let me see here what's going on. I'm sorry, folks. Computer is locking up at the most inopportune time.
Neil, do you want to send it to me and I could try to? Oh, it looks like you got it now.
Yeah, it's not doing what I want it to do here.
We can see it in that minimize mode there.
If you can see that, yeah, I'll try to run it this way. Is that visible to you guys?
Yeah. Yep.
Okay. Sorry about that. I don't know why it's not working in presentation mode. In any case, our U.S. health system footprint, this is a partial list. And you can see that many of these systems that are out there probably represent. Hey, David, do you have me muted or no? Or are you muted? I think when you mute yourself, I don't get echo.
Oh.
There we go. Let me see. Perfect. Sorry about that. So really what we've got here is a myriad of accounts. We have any number of different IDNs with whom we're working closely. And they represent some of the greatest innovations that we've been able to accommodate thus far. So as an example, UPMC here in the upper left if you can see them. University of Pittsburgh Medical Center, they are what we would term a payvider. So they're in both provider space, they're in the payer space. Community health systems down in Tennessee, Brentwood, Tennessee, they are utilizing our system for home health. And Trinity Health, if you see them up there in the upper middle part of your screen, they're also using us, Vivify. They've engaged us for home health initiatives. Memorial Hermann, also a home health initiative. UCLA Health are managing CABG patients post-discharge. So any number, Cincinnati Children's began in the oncology space, Robert Wood Johnson in New Jersey. A variety of different facilities that we've got under contract right now that we're working very closely with to accommodate any number of different clinical needs. But again, I hate to go back to it and reiterate the obvious, but Katie had mentioned engagement, patient engagement. Each one of these hospitals or facilities is looking for a different, newer, more aggressive way to engage their patient population, and Vivify has helped them do that. Some of our best ideas come from these health systems. So just a little bit about clinicians and patients, and the translation of ease of use equals translates to basically optimization, workflow optimization, and patient compliance, patient engagement. We call our platform Vivify Pathways, and we're going to speak a little bit about the ubiquitous engagement levels that we've got here. So if you look here at the right side in terms of the spectrum, the genesis of the company was really to treat high-risk patients, so those that were most at risk of rehospitalization. And the idea was to accommodate prevention of that readmission for that patient through something called Vivify Pathways Home. So it's a fully managed kit, and we issue a fully managed kit to a patient upon discharge to the home. It's essentially a Samsung consumer-grade tablet, and we couple that and pair that wirelessly with a Bluetooth device. The standard kit is a weight scale. We also have a blood pressure cuff and a pulse oximeter. And through a series of daily care pathways questions, we're able to assimilate what that patient's condition is, capture some biometric data from that patient, and also have them answer a series of questions about how they're feeling, how they're sleeping, how they're reacting to their medications. The average daily experience for the patient really is one of about 4 to 6 minutes. We don't want to go any longer than that because we find that it becomes tedious for the patient and the engagement levels and the compliance levels drop. As you go left on this screen, you can see that it's a rising risk. These are more complex chronic diseases or managed health. They may have early stage disease. We have added all 3 of those modalities, the Pathways Home Virtual Visit Kit, Pathways Go, is essentially the same type of patient experience on a smartphone, and then those that many of you probably in upstate New York can relate to is the idea if you do not have a smartphone or you do not have 4G or 3G for that matter, wireless access, you can accommodate the patient experience through Pathways Voice, and this is through a plain old telephone service or a POTS line out of their home. So we have all 3 of those modalities that are available to the patients now, and they essentially are capable of helping the patients regardless of where they are, upstream or downstream in this continuum of care or in this risk factor. They're able to accommodate capturing patient data and being able to more effectively engage the patient. What we're looking at now in this fee-for-service shift to value-based care, when you speak to your payers or you speak to your VP of Payer Relations or your quality folks in your organization, and you understand who are they targeting, who are they most interested in possibly assisting, really this 5% of the top of the pyramid, this high risk, the complex illnesses, they're costing the most. So you could, depending upon where you are, what your payer mix is, and really who you're looking at supporting from a patient community perspective, that high risk 5%, the sickest of the sick, could be costing your health system anywhere from 50% of your overall cost to 65%. Give or take. It's different everywhere you go, but the general consensus is this red triangle of 5% at the top is is really the most expensive and most costly patient population or cohort that folks are looking to get on top of and manage most aggressively. And then the rising risk and at-risk and healthy are to follow. So we built a system that really goes across the continuum and is able to accommodate all of those needs. When we look at the single end-to-end platform, there's, again, another way of saying the same thing as the modalities, the Pathways Home, Pathways Go, and then the remote care platform. All of that information is gathered in one central location on the patient care platform or the care team platform. It's a portal where their information resides, and you can manage that patient experience in almost near real time. So just a little bit about Pathways Home. I'm not going to insult you folks by reading this to you, but really it's the idea of a turnkey solution for any population, enabling patients of any age or technical ability to really reach out and maintain a high-touch daily profile so that your care teams can manage them. So if you look at this fully managed kit that we issue to the patient, all of these elements are built into it. So the cellular is built in, the virtual visits. This is really where, in your guys' world, the virtual visits is the telehealth, telemedicine. You could actually put a mid-level or a nurse or a physician on a face-to-face video call with a patient as the patient may be decompensating or trigger alerts and may wish to speak to a caregiver through a virtual visit. That's fully capable through these devices. Customized pathways, any condition, any language. We basically have about 80 or 90 clinical pathways from COPD to CHF to complete joint replacement, pneumonia, brittle diabetic, hypertensive diabetic, you name it. We can build it, or they already are built to accommodate those patient cohorts, and you can have them built with comorbidities are included, and you have the capability to drag and drop on any of those customizable pathways in real time for any patient, down to the patient level, cohort level, whatever level you wish to manage. So medication reminders, health tips, all this is remotely managed, and we can provide remote control support in near real time to have our 7x24 help desk dial into the devices and help those patients that may need assistance. And then logistics services we can ship to and from directly to the patient home or to wherever it may be convenient for the care team. We're continually looking at device integration. So right now, the standard issuance would be a scale, blood pressure, and a pulse ox, but we have glucometers, temperatures, spirometry, and we're constantly evaluating and vetting additional device integration to our platform. If I look at logistics here, this is really another way of saying there's a myriad of ways that we can integrate logistics services for you as a client. Point of care onboarding, we can onboard them at the hospital, we can onboard them at home. We have full bi-directional EMR integration. The daily monitoring is by your care teams that may be in the field or centrally located. We also have services that can add or augment to that. And then, again, in-home care delivery, scheduled kit pickup, testing, and inventory management. We can handle that soup to nuts if you don't have the capacity to do so yourself. So really that's really the kit logistics and the full spectrum of what that is for the patients. If you look at Vivify Pathways Go and Vivify Pathways Voice, much of that capability is mirrored in those two platforms. And what I'll do for the sake of time is just suggest that we have write-ups for the Pathways Go, and we also have write-ups for Pathways Voice that we'd be happy to share with you. But for the sake of time and being respectful of your guys' schedules, I'm going to truncate that area of the dialogue a little bit. Some things that you can see here with respect to the rich clinical tool sets that we have. This gives you an idea of role-based access and views. Patients can be prioritized. So when your care teams are observing what the patients are, if they've exceeded acceptable thresholds or they are alerting These views are prioritized, so patients are basically managed by exception is the term that we use. So you could have 200 patients out there that are being monitored by your teams, and should 195 of them be static and in pretty good shape and not trigger any unacceptable thresholds or excessive alarms, then you can pay attention to those 5 patients that are probably the sickest of the sick for that day and decompensating and need your attention, either with a home visit, a virtual visit, or just a telephonic phone call and support. And that prioritization is entirely up to you in terms of how you want to organize that. You can filter them by category of care, or do any number of thresholds and filters to apply to a specific cohort or patient group. What we're seeing is, and this was probably alluded to, and this is probably a central theme to ATA, is that we're seeing scalability to all populations. There are folks that are self-insured, employers that want to look at this. There's payers and health plans that want to look at this. There's coordinated care, population health. A lot of folks are seeing a general maturation of a couple different things. One, you guys see it firsthand in the telehealth world, the reimbursability and those factors as it relates to the reimbursement of telehealth. That's a huge component now that's really being explored and vetted and becoming more mature, even across state lines or over state lines. And then, of course, to the extent that fee-for-service is going away and very, very rapidly morphing into a value-based care initiative, to the extent that you can manage fully capitated plans or partially capitated plans and control costs and also develop positive outcomes financially and clinically, that's exemplified across all these populations, so it's very much the focus of many, many folks. Guided by evidence-based care, we, again, I kind of alluded to this earlier, evidence-based clinical care plans, many of them already built, and really unlimited customization with input from evidence-based care organizations and best practices. One of the things that we can do is customize a patient experience every day. And this is a bit of an eye test. I'm going to apologize because I couldn't get my full screen to behave there, but this gives you an idea of what a congestive heart failure program may look like Monday through Sunday. And there's a variety of questions here that are asked, biometric data is captured, and then say on Monday we're going to push a video to the tablet that describes the medication. And then we're going to give medication reminders or dietary reminders on Tuesday, and on Wednesday there's a video there describing their clinical condition. So this all goes back to engaging the patient at the highest levels on a different level every day so they don't become complacent and their compliance level remains high, and it enhances and completes their clinical literacy and makes it better every day. When we talk about compliance, by compliance we mean all of these questions and all of this biometric data every day is responded to. If it is not, and they miss a day or they miss a question or fail to respond to a question on a day, they're not compliant for that day. So our average cohort, because of this level of engagement and this customization, is 77 years old, and our average compliance across the board over thousands of kits that are issued in the field is over 92%. So an older cohort, easy to use, and high level of compliance. And because of some of these exclusive education tools that we have, videos, different engagements, you can add your own for no cost. These things are really helping drive compliance and clinical literacy. Just a few more points here that I can show you. Comprehensive reporting. We have the ability to report against kit utilization, patient compliance. You can break it down by the cohort. You can understand who's using what kit utilization reports or patient-centric reports, who's compliant, who's not compliant, who's answering the questions and entering their biometric data manually versus who is doing it in an automated fashion. That way you can get a sense for maybe who's gaming the system versus who's utilizing it properly or maybe overwhelmed a little bit and needs just a quick refresher on the technology. These reports allow you to really maintain that high degree of compliance and patient engagement. For your IT folks, we are fully integrated with several EMRs. We are very, very open and supportive of the idea of bidirectional full interoperability between your existing EMR systems and our system. We grew up in our respective previous companies believing that Data should be provided to everybody for any reason at any time, and so we've been able to provide that bidirectional interoperability for a number of different platforms. So this is another way of saying to your IT folks, we can help you protect your investment and will in fact enhance that investment. One thing that I'll wrap up with just ever so briefly is the idea of it's a great system. It does a lot of wonderful things, but does it translate to outcomes? And the outcomes are there. We've seen repeated, viable, repeatable, scalable outcomes from our experience. And so what we oftentimes see is, if you look at the outcomes here at the top, we're consistently seeing a 50% reduction in readmissions. This one particular one is highlighting, I believe, Christus Healthcare, which had a HIMSS IRB, and they published that. But generally, we see about a 50% reduction in readmissions. Again, 92% patient compliance is what we see. Huge patient satisfier. 25% reduction in LOS. That's a home care LOS reduction. I need to update that slide to provide a little additional clarity there. Over a 60-day home care episode, you'll see a reduction in home care visits as well, and we've seen significant cost reduction as a byproduct of that. And so there are a series of case studies that we have that we can provide you should you need them across a number of different clients that we showed earlier. Alignment is one of them. Another case study here with Intermountain Health. We also have I believe, what is this one here? I can't see it because the Memorial Hermann, I believe, down in Texas. They are a large ACO down in Texas. And then Children's Health and Christus as well. So Christus Health started managing some of the remote care platform initiatives back in 2012. So we've seen, again, you'll see a consistent benefit right in here. You're looking at, having the readmissions and then having them again. So we're able to consistently across the board, 2 years running, able to produce some very favorable outcomes and very favorable results. And I know I hustled through this. I think I got thrown by the fact that I couldn't go into presentation mode, and it kind of got me sideways there, so I apologize. I wanted to make this highly engaging and hopefully not just too much too fast, but here's my contact info. David, hopefully this screen is continuing to update. You can see that come across. And
yep, sure
with
can.
that, I'll be open to any comments, questions, or input. Hopefully I'm falling into the time range that's acceptable.
Yeah, you're perfect, Neil, as always. Just a couple of thoughts as we kind of follow up on that. If you look across, the folks that are on the call today, and what we're all about, those patient outcomes are really important for all our respective PPSs as we work on the district project across New York State. There's a huge opportunity perhaps to accelerate the outcomes on many of those projects. So did want to give you the opportunity to hear from Neil and ask him any questions. I know many of you on the call have at least looked at remote patient monitoring and you're engaged with population health. So now's your chance. If you got a question, go ahead and raise your hand and I can unmute your line, or you can send me a chat box question. And I'd be happy
David,
to,
can I comment on the district piece too?
Yeah, go ahead.
Super. Just one comment. I'm glad you brought that up. One of the things that I had a conversation with a peer of mine that I used to work with in a former life. She's now over in the Rochester area, and she had mentioned to me about disrupt. So I did some initial digging on the disrupt program and uncovered some ideas that I'm happy to share with folks. In fact, David, you and I had some dialogue on that. It was very, very helpful in terms of being able to identify areas that Vivify might be able to assist as an accelerant to what your organizations may be doing with respect to disrupt. areas that we might be able to help provide a scalable solution that would add to any ideas or initiatives that you've got within the district fold. Happy to have that dialogue. There's some areas that we really can help the rubber meet the road there. So thanks for reminding me on that.
Yeah, right on. Some of the things that we especially liked about the remote patient monitoring solution from Vivify Health were those customizable care plans. You know, as it turns out, I think they gave us a lot of information to really help build care plans, but just the option of being able to customize them was a great advantage. And then, you know, those educational video pieces and being able to add our own, if possible, those were some kind of really nice features in addition to the types of questions that we ask in order to engage and educate patients. So it's working out really well. Neil, I'm not seeing any questions at this point, and that's okay. Neil's contact information is there. If you have any thoughts or questions to follow up on, you can send them my way, and I'll be sure to make them available to Neil.
Be great.
So,
yeah,
Neil, I just want to say, kind of as I let you go here, that and Neil has, you know, not only been a tremendous resource to us here, but I am proud to call him my friend. So thankful to have Neil as a part of our team, and just grateful to have you on the call, Neil. Thanks.
Appreciate it. Thank you, David, for the opportunity, and look forward to continuing our work together. Thank you as well. It's been a pleasure.
Thanks, Neil. All right. Let me take back control here of the presentation, and let me just confirm that. There you go. So just a couple of things to make you aware of that are coming up. Of course, is it really actually just next week? Yes, it is next week. The Northeast Telehealth Resource Center Conference. It's May 23rd and 24th in Amherst, Mass. Katie and I actually will be presenting one of the breakout sessions, so hope to see you there. We're going to be kind of talking about our 12-step process, which many of you have heard about before. But if you haven't, that's a great opportunity to hear from us. But then there's some other great presentations along the way that you'll want to jump on. Let me just see Andrew Solomon. I'm going to unmute your line. Any one last plug on that thing?
Well, we're certainly excited that you and Katie will be there, David, and I think we have a great group of folks throughout the region. So I'm excited, and I think we'll have fun.
Yeah, it should be a really good time. And we'll learn lots, as always, because we always do. And then finally, the other big event coming your way, not until later in this year, but November 2nd, the third annual 2017 North Country Telemedicine Conference. Got a little tagline there, IOUs in telehealth, implementation, optimization, and utilization. Sounds like we're going to learn something, I'm sure. So that's Thursday, November 2nd. Katie, any thoughts you want to add on the conference?
Yes, this is Katie. I am still considering, or we are still considering presenters. So if anybody has any ambitions to present at our conference, please let David or myself know. We're still considering a few open slots. We have some great presentations already lined up from Elizabeth Zakari of HCR Home Care, and our keynote speaker this year will be Dr. Irina Gelman from Fulton County Public Health, and we have a couple of other great breakouts planned. So we're looking to make this the biggest conference yet. It is our third annual, so we haven't been doing it very long, but Look forward to that invitation coming out in the next several weeks. It should be in your inboxes, so we hope that everybody on the call can attend.
All right. Well, thank you, everyone. We have reached the conclusion of our agenda today, so thanks for your attention. Thanks for participating. If you have any questions or follow-up after today, feel free to give me a call or email. Contact information is here. So look forward to seeing you all at the Northeast Telehealth Conference next week. And with that, we'll let you go. Thank you all.
Thank you, everyone.